welcome to the Telemedicine Echo. My name is Beth Munson, and I am the coordinator for this Echo. I work for the University of Missouri and Missouri Telehealth Network and Show Me Echo. And I am now going to turn this over to our facilitator, Evelyn Nelson. Hi, Evelyn.
Yeah, good morning and Happy New Year to everybody on the call. Great to see so many folks online. I'm Evelyn Nelson, so I'm the PI for the Heartland Telehealth Resource Center, and really pleased to continue this series into 2022 in partnership with our Missouri and Oklahoma colleagues. We're really glad to have you all joining us today. I wanted to start off just asking Jerry if that is a screenshot or if that's just beautiful Missouri behind you, because it looks just perfect.
Well, thank you. That is actually out of my office. It's over our garage. I've been working pretty much from home for close to 2 years now. So it is here locally in Missouri, but it was a picture from last year. We still have snow, but not that much right now. So thank you.
It's just beautiful. With no further ado, I'm pleased to introduce our colleague who's going to kick us off here with our didactic this morning. Tim Davis is an accomplished telehealth leader that we're really lucky to work with. Tim is the lead for telehealth at Oklahoma State University Center for Health Sciences. He's our state PI for the Heartland Telehealth Resource Center. And then also he is the executive director for the Telehealth Alliance of Oklahoma. You also want to listen up real close. Tim has a wry sense of humor, so I know he'll be sharing many good lessons today, and also I'm sure give us a laugh too. So welcome, Tim. We appreciate hearing your talk today.
Evelyn, your recognition of my background and saying that Tim has a wry sense of humor, I can't resist. So Tim, is that a naturalistic landscape behind you from Oklahoma?
It is. It's one of the more beautiful places in Oklahoma, but no, they kind of have me in a little dungeon here looking things. So
no,
we're actually very lucky. Our campus is right near the Arkansas River, and we have a great view, but just not from my location. So
no, I look forward to your talk. Thank you.
Thank you. And I love your pick in the snow, but hopefully you keep that snow up north. It's nice to look at. I don't want to drive around in it. We don't know how to drive in that in Oklahoma. I'll just say that. So, but Evelyn is right. I do have a wry is a nice way to say it, sense of humor. So only about half of what I say is going to be serious. The other half will probably be jokes that are only funny to me. So anyway, this will be very informal. Again, the next 3 to 4 hours, we're going to go painfully deep into technology and really ask any questions you have. Raise your hand, put it in the chat, whatever. So we'll get started here. Let me share my screen. All right, everyone see that okay? Yeah, okay, awesome. So again, we're going to talk about how do we choose technology. So again, with telehealth, we have the clinical side down, fantastic. What is the key piece in telehealth? And that is the technology. How do we interact with the patients, with providers, et cetera. So we'll just kind of talk about this real quick. And again, feel free to ask any questions. So to start off, there really what I see is kind of 4 main types of telemedicine and telehealth. We have the synchronous or live interactive, where patient providers are communicating, two-way real-time via a video conferencing system. This allows providers to access or assess patients using medical scopes and equipment live. We also have asynchronous or store and forward, where we have electronic transmission of a recorded health history to a clinician, usually a specialist, maybe demographic data, medical history, lab reports, image, video, sound files, etc. Use this when a face-to-face visit is not necessary. Something like radiology review, second opinion for dermatology, etc. The third would be remote patient monitoring. This is where you use connected electronic tools to record or capture personal health medical data in one location, like your home, for review by a provider in another location, usually at a different time. So there's an opportunity to extend care between and beyond hospitals and into the home. So here we have kind of some neat technology. You have tetherless sensors, pulse ox, blood sugar, wellness checks, those type of technology. And then finally, we have the mobile health. So this is healthcare, public healthcare information provided through mobile devices such as cell phones, tablets, laptops. This information can range from targeted text messages that promote healthy behavior to wide-scale alerts about disease outbreaks, etc. So here we just kind of have some pics of some of the different pieces of technology we can use. And really what I find is telemedicine technology can be boiled down to really basics of broadband connection, video platform, and ability to record, tech support, and peripheral devices like we see. A solo or small group practice can still conduct telemedicine visits the exact same way as a large hospital system can, just usually on a smaller scale. A good telemedicine system and technology will allow for peripherals, otoscopes, steps, dermoscopes, etc., to be added later. So in here we have a picture of a telemedicine cart that may be very basic at first, and then we can advance into the other scopes, cameras, or devices at a different time. The telemedicine cart, of course, it's an option to incorporate all of the hardware into a rolling movable unit. And the cart can be stored away when not in use, then brought into a room when needed. So really, one of the other key factors in telehealth technology is broadband access. And broadband access is now recognized as an important social determinant of health, as well as a public health issue. We have approximately 19 million rural Americans living in digital deserts without broadband access. And that's something we face quite a bit here in Oklahoma. Western Oklahoma, southwestern Oklahoma, there are certainly large areas where we just do not have broadband access. Speaking of broadband, it kind of breaks down into really the key piece is bandwidth for your internet speed, or the speed of your internet connection. That's how much data can be received and sent between your device and the internet per second. Maybe you do have some broadband, or you're right on the edge to have broadband, and it's very slow upload or downloads. You may have difficulty uploading some of that data to your provider, or even being able to do a video conference with your provider just due to your connection. It's always a good idea for providers and the patients to test your bandwidth at different times of the day, as the speed may change based on maybe the number of devices being used, the number of users accessing the internet, etc. You can go to www.fast.com, and that's a free service to test your internet speed. Very easy. You can get on there, type that in, and they'll show you exactly your upload and download speed. Pretty nice. So really we have, me going crazy, there we are. We have some technology trends, web or link-based. So we're not really downloading anything to any your computer or device. You just go out to the web, right there you have your access. Direct to patient or direct to patient in your home. Mobile platforms like we talked about before. And then really some of the real keys are deployability, scalability, reliability, and ease of use. So this program or technology or system that we have, how easy is it going to be to deploy out to all the providers and to the patients? Scalability, is this going to be great to use for one or two patients or providers? What if we want to expand that to other service areas or providers? How easy is it to scale? And of course, reliability. We want this to use your system and technology to work every single time that we need to use it. And ease of use, really one of the most important as well. How easy is it to use this device? Is it something that I'm going to have to figure out every single time? Can I just jump on and really work it with only a minimal amount of training and be able to use it successfully every single time. So really, by breaking down the process of technology assessment into a series of executable, repeatable, and documented steps, we can be more informed and confident in our selection of what technology we're going to use. The implementation of technology system will require a team approach. So it's not just IT creating this or deciding what we want to use. It's not just a provider or clinician saying, hey, I saw this device or this technology. I think it'd be great for what I want to use it with. It's not just one or the other. It is a complete team approach. So you want to have equal parts, clinical, technical, operational systems, everyone weighing in on our telehealth systems and technology. We do already have a lot of the expertise, most likely in your organization. Again, most organizations have a technology or HIT, HIM specialist that can help out. We do want to have, our critical outcomes of technology selections can be failed pilots, delayed programs, system incompatibilities, clinical use dissatisfaction, increased expense, and even patient dissatisfaction with the system and technology. So some of the important questions, again, we need to ask are, do we have administration approval and understanding? Do they fully understand what are we going to be going through and how much time is it going to take, not only from a clinician, but again, from an IT and tech standpoint? Do we have the right people or stakeholders at the table? As I mentioned, we need to have everyone from in the organization essentially represented at that table. We need to have champions as well, someone who really can champion this from their side of the organization, because there will be setbacks, there will be costs involved, and will be pushback. So we need to have those champions to help us get this moved through. And how do we actually measure success and failure? Is it success? Is that from a technology standpoint? Is it 99% uptime? Is it minimal amount of downtime? How do we measure and define that? As I said earlier, is this technology or process scalable and tenable? Can we get a small scale and then roll it out as we expand our technology system? Does the technology play well with the others? So what happens frequently in the past is someone might, maybe a clinician, I don't mean to pick on clinicians, but maybe a clinician might see something and they want to use this and be great. And so they buy this and implement it, but it doesn't necessarily play well with the other piece of technology we have, or we can't scale this because it's very proprietary and not an agnostic platform. And then how do we measure patient and provider satisfaction? So again, along with, how we measure success and failure, are the patients and providers satisfied with using the technology and the system and process that we have in place? So what we'll go over next is just really, it's a three-phase telehealth technology process overview and assessment. And I get this from the telehealthtechnology.org. They are the National Telehealth Technology Assessment Resource Center, and they have a great toolkit here. So instead of reinventing the wheel, we'll just kind of go over this and walk through the different steps. It looks like a lot of steps, but really it just kind of makes sense. It very much flows. And it's very important to have a process involved when you do a technology assessment or choosing technology. If you don't, again, you can have products that don't work with each other, products that only work for one service line and not necessarily another service line. So we just want to have a good understanding of what goes into the assessment so that's consistent and repetitive. So when you do start selecting technology, we know we have the right technology. So again, there are three phases really. A needs assessment. That's where we understand the needs of the program and the solutions that might meet them. So we'll establish requirements, do a market review. The second phase is testing. We'll create, execute, and communicate a repeatable testing process that evaluates devices against whatever your organization might need. Repeatable is the key piece. So we want to consistently be comparing apples to apples on a device or piece of equipment. So we want that to be repeatable. So we'll procure, we'll grab a device, we're going to plan our test, then we'll test that plan of that piece of technology or device. And then third, we'll have deployment and support. Purchase, deploy, and support the devices. So we'll select which one, and then we'll deploy and get those devices out into the hands of the provider and patients. So step one really is, again, the requirements. So we're going to create a needs assessment. And here we generally are supporting a decision to either implement a new telehealth system or program, to expand an existing telehealth service or line, or improve or even remove a disparity in a certain service line or area. So really we need a clear understanding of what needs we're trying to address and how exactly we expect a device or solution to address those needs should be really the first step in our assessment process. So that's something to keep in mind. What issue, what problem are we trying to solve buying a piece of equipment or a piece of technology? So establishing the requirements. So we want to compile this information, all the information we get here, in a manner that's really useful to those who will be actually performing the technology assessment. It's important, again, to pull together people from all areas of the organization early in the process, so that, again, the clinicians, the technical experts, administration can all have provider input. So step one, needs assessment. Again, we need to clarify precisely what is desired in the implementation of a new telehealth service or program. Then we're going to have a position statement. This provides a high-level view and helps explain why you want to start this endeavor and what the end goal is. This really can help give people who join maybe the project later on a clear vision, and help provide some guideline to future decisions. So, maybe we started this and someone else has joined later, administration comes in later and wants to review this. This gives us a good opportunity to have this position statement so we can go back and review exactly what our goals are here. We'll want to create a user profile list. So the user profiles, this helps define a set of needs that are required during the assessment activities. So everyone who'll be using the technology and how they interact with it will be your user profile list. We'll also have some user cases. And so while the user profiles we just created look at who will use the system, the use cases will show how they plan on using the technology or device. And then we're going to create requirements. So this is a list of features that devices must have, as well as a list of features that are desired. And then those are either unnecessary or detrimental, things we do not want. So must-have features, absolute minimums, and then the nice to have, as well as things we really do not need. So we don't want to spend any additional money or time on those. And then the last piece of your requirements is really the SWOT analysis: strength, weakness, opportunity, threat. So, if we can establish a list of resources and concerns in the assessment process, the SWOT will really does require input from different areas of your organization. And so it really will help refine what we're trying to do and why we're trying to do this. Second step is a market review. So really want to see what's available out in the market, what devices, what technology, what systems are out there. And really this review should include discussions from vendors and manufacturers and even other third-party assessments of the devices or systems. And this can include other telehealth programs, other health systems that have already implemented similar programs and technology. You'll want to look at product specifications and really do any and all other research you can on the device, how it works, again, how the interoperability is as well, and just to get a good idea of what we have. It's easy to sit back and just kind of daydream of a perfect platform and device, but now we're actually seeing what is out there and how we can use it. So we're going to identify the device features again. So we'll gather manufacturer information. It's going out and just seeing again what's out there, what do they say, how this product will work. We're going to create product cut sheets, and this really is just a list of specifications and how the device works. And then next we'll create a list, a device list with the features. So again, here's the devices, what features do they have? We have Bluetooth stethoscope. We maybe have one that's just a stethoscope. We have another that has a stethoscope and an ECG. So we'll list out those devices separately because they do have different features. Then we're going to find a third-party review. Like I mentioned earlier, no sense is going into this blind. There's so much information out there. Go out and find who's already used it. What do they think? Give feedback. People like to talk about the process and their systems and what they're doing. So, reach out to these other groups and talk about what they're doing, how they're actually using it, and how it works, what they liked, what they didn't like. Then we're going to identify some useful features, such as how the technology works. And then we're going to create with that a technology overview document. And that really just explains, again, how the technology works. And it also lets the testers know what to expect and how they can explore, the ties between maybe that technology and what they have or what they're wanting to implement. So it seems like a lot of different steps, but really once you start, it kind of just flows into it. And again, the whole point of this documentation earlier is that we can have a repeatable process, and then also something you can show for if things go, don't work out. You can go back and review all this information and see maybe what you're lacking or where you can improve on next time. So step 3, we're actually going to procure some devices, and we're going to contact the vendors and organize these test units. So this is where the active physical assessment of the device will happen. We're going to get the right devices brought in. We're going to test, plan out, and plan the exact test that each device will be going through. And we want to be consistent when executing these tests. So again, apples to apples comparison with these. So we want to have a list of organizational requirements that we want. And really we'll kind of generate these from user profiles, from the use cases, from known needs, and then compare these to the output of our testing. So when we contact vendors, what I found is most of the vendors, especially if you're going to be buying more than one unit of something or one device, they're very amicable to loaning out units. If you say you're looking at getting a certain stethoscope and maybe a vendor has multiple, kind of let them know what you're looking at, what you're needing, and they'll send out to you a loaner unit, and you can keep that for X amount of time and really test on that. If you can't, or you're looking for a device that's really the vendors just don't loan out, you may be required to purchase like maybe a single evaluation unit for your testing. And this can seem like an additional expense, and it is, but in the long run, it's better with the price of some of these devices are costing. It's better to go ahead and maybe buy one, try it out, make sure it exactly works as needed before buying, 10 or 20 or whatever your number that you need. And then we'll organize the test units, get everything ready to go to do the testing. So step 4, that's when we're going to plan our test. So here we're going to, the important piece is we need to identify participants. So again, this is really a group. This is a group process. We don't want to just have IT testing. Does it work? Does it turn on? Can I see the camera? Maybe it works for IT, but from a clinician side, maybe it's a derm scope. Am I actually able to see the skin and actually have measurement marks on there that like I need to see? Does it record or take pictures like I need to? So we want to identify the participants, get everyone at the table for the test, and create a test set. So we want to test certain things, some functionality. Is it working as it should and as it states? Does it work for what the clinician needs? Usability, again, how easy is it to use? Is it something I can not use for a month because maybe I don't have that many patients with that I'm going to need this, but then when I do pick it up, falls right into place and I can easily use it. Even the mechanics of it, is it something that, do I need to charge it? Do I need to plug it in every time? Can it just stay there? Do I need to turn it on? What are the mechanics of the device and the system? The interoperability, again, is it something that really is easy that just connect your uploads or downloads what you need, or do you have to do certain, save it and file transfers, things like that. Even the security, again, how is the patient information collected, stored, transmitted, and protected on the device? So security is something we very much need to pay attention to these days. And then create a scoring system. So this is where, it can be something as simple as pass, fail, a scale of 1, 2, 3, or a scale of 1 to 10, but create a scoring system so that each device you have and that you try out and test, everyone gives it a score, and that you can go back and easily compare those scores. And then really create a testing schedule. So what is a schedule of who has what product, or when can we bring it together and everyone be at the same table testing these products at the same time. I'm going through this kind of quick. Any questions, comments so far? If no, I will just assume you guys are enthralled with what I'm talking about and keep on. Okay. So step 5, testing the plan. So this is where we will, again, follow the plan that we had set up to plan the test. Now we're going to test that plan. We're going to document, evaluate results, and if needed, do a secondary assessment. So this is where testing the plan, we want to attempt to test all the devices on a single criteria at a time. So if you have multiple scopes, cameras and different lenses, you want to test, maybe the derm scope on all the different cameras at the same time. Don't just test all the different lenses that are available for that scope. Test all the different derm lenses at one time. So you're comparing apples to apples, as I mentioned. This allows you a more thorough comparison and how each device relates really to each other. So again, try to do the test at a controlled environment as well, especially at the same time, as I mentioned. You don't want to do something like a camera or a lens where maybe one day you're doing it and it's you're by a window and it's very sunny. Therefore, your results might be very bright or washed out. Another day you come back and you're doing it inside in a room with just some lighting overhead and it looks completely different. So try to have a very comparable controlled environment whenever you are testing. We want to document all the testing results. Again, this is going to be an important part. If you come down to maybe devices are very close and similar, everyone's scoring very similar, go back to your documentation of notes you may have made so as to maybe help you pick the correct and best device. And then after all of the assessments completed, you want to gather, again, everyone together, the testing team together, and just discuss the numbers, evaluate the results, go over what did you have, what do I have, let's see how we scored each device and see what everyone's thinking. And then actually have the devices on hand as well. This makes it very easy. So if you had a question maybe on you thought one device worked better than A worked better than B, but B maybe was easier to use or handle or set up, have those devices there so you can go over that technology and wash out any kind of questions you might have. And if needed, maybe you come down and the results are pretty even across the board, or maybe the results are that you don't like any of the device or technologies that you brought to testing. You might need to get a secondary assessment or go back out and start that process again. In step 6, selecting the device. So this is where after you've done the overview of the test, the results, and I got the feedback from the testing team, now we can go out and decide which device really is the one we want and we want to go with. So we're going to do, again, testing, review, and final selection. Go back, review all the documents, make sure everyone's on board and agreeable, and not just maybe a clinician wants product A, IT, maybe is, say that doesn't work well with our system, we want to go with B. Make sure you guys are on the same page. And then disseminate that information. So once we've decided we're going to go with the device A, great. Now we need to get that information out. So we want to really probably create a high-level summary document and send that out to everyone that was on the team, clinicians who are going to use the device, administration, letting them know where we are in the process and what we've chosen, and really any other partners in the project or any other stakeholders to let them know, hey, we've gone through our testing, we've decided on a product, and we've selected that. It's also a good time to kind of inform all of the stakeholders involved in the process of any upcoming milestones or deadlines that may impact them. Maybe plans to ship or deploy the equipment, purchasing timelines, training options, all those things that will exist as the implementation process continues. So really that's part of the dissemination of information in the assessment overview document. And then really the last piece is the deploy. And really this is where people probably think this is the easiest piece, right? You just buy it and get it out there. And really this is probably the most time consuming and then what is an ongoing process. So especially from a support standpoint, from an IT technology side, it's not just we buy it and implement it. It's now we have to support this product. So we want to purchase. So of course, like anything, as the size of the deployment, the more we put out there increases, so does the complexity of the purchasing process. I know in our organization, if it's over a certain amount of dollars, we have to go through multiple vendors, get multiple quotes, things like that. So, the purchase process can take time as well. So we mentioned we have clinicians involved, administration, IT. We also need to have even purchasing on board to how soon can they get something in, who's going to keep track of all that and make sure we're on track of getting it on our deadline or our goals. Do prices go down if purchased in larger quantities? Does it make worth our time? Maybe we only need to deploy 5 at this time, but do we want to go and maybe purchase 10 because we have a price break at that? And we do plan on deploying more units at a later time. We need to make sure the make, model, and any additional options that those have or features are listed very clearly with purchasing so that the correct equipment is purchased. We've had probably all have had that happen. We think we're going with product A with option 2 and 4, and then for some reason we get the product from purchasing and it comes in, it's maybe we don't have exactly what we thought we were ordering. So again, a lot of information there to communicate with purchasing. Then we're going to deploy. So we're going to send this technology, these devices out into our organization and providers. Just with purchasing, the complexity of deployment, of course, increases with the size. So if we have more devices, more service lines, more providers in remote areas, all these things can cause this to be a troublesome, process. So we want to establish a testing plan as well once the devices have been received, installed, configured by the insights. Do we want to have, again, that product coming into IT, they set everything up and test? If we have a remote site, do those things get shipped out from the manufacturer or vendor directly to their site and they set up and test? If maybe you're doing a telemedicine cart or you have a piece of the technology equipment that requires other pieces, you may want to wait and do what's called kitting or put all those pieces together on the equipment. So again, if I'm doing a cart, instead of sending the cart out and then waiting for the stethoscope or a horoscope, something like that to come in and then send out later, I might want to wait, get all those products together and even set it up on the cart, test it, and then set that cart out, fully kitted out, so it's ready, 100% ready to go. And then support. So this is really where, from a technology IT standpoint, really your work is almost kind of beginning. You want to have some kind of service level agreement. It's a very useful tool. That's who can be responsible for which service lines, along with response times, uptimes, maintenance, who is responsible for all those things. And then do we have any spare replacement devices on hand? something else to keep in mind. Maybe you want to have minimal downtime, 99% uptime. So if you want something like that, you better have some spare devices or technology on hand. So if something does go down, doesn't work, breaks, you can easily put in a new piece. And then training. Yes.
We have a question that fits in real good right here, if it's okay to ask you.
Absolutely.
This so much rings true with some of the challenges we face too. Do you have any advice about getting provider buy-in so they agree to start at a smaller scale before going all in with a full-blown remote patient monitoring with video visits? We're getting a lot of provider resistance on starting at the smaller scale. They want the whole enchilada to be implemented at one time, but that type of implementation is not reasonable at our size.
Absolutely. I think it's just it's great that the provider wants to go all in, and they're wanting this. They're kind of championing it. That's fantastic. But it's like when you're cooking, right? I mean, you taste along the way as well. I would suggest you want to get a small victory. And I think the small victory, the small wins will only help that provider and help you in growing the project. So you really just kind of maybe need to talk them off that ledge a little bit of instead of just thinking huge and we're going to distribute this to all of our patients. Let's start out with maybe 10% of that, a smaller portion, and just try to talk that provider through of hey, let's make sure this all works as we think it's going to work. Let's get that victory under our belt and that documentation that it works and we can grow this. That's much better to start small and to grow, even if you're growing quickly, versus starting out too large and then it gets ungangly, it's not working like we want to. Then that is not good for patient satisfaction, even provider satisfaction, potentially spending a lot of time and money, correcting items versus rolling out new stuff. So I don't have any particular tricks other than just, again, trying to talk to them that you're impressed, they're wanting to embrace this and really go out there, but we really need to start baby step, start small, get that win, that victory, and then let's start rolling this out in a later time.
That communication piece seems so important with that clinician who's gone all in, just like you were saying, seeing if they can help with the smaller scale so they know it's not off the radar, it's just part of the process.
Absolutely. And whether it's a service line, maybe you want to start out with one service line, maybe you have multiple locations, maybe you want to start out at just a smaller location or one. Really, all that can do as well is that can just help the entire organization that you can go to them as the expert as well. Hey, you roll this project out. Let's have you involved in our rollout as well, or even scaling this process. So you just don't want to scale on a 1 to 10 scale. You don't want to start at 10. Start out at a 1 or 2. Again, get those victories and then easily ramp up to a 10. This process is really almost like any kind of a project, really. So in real estate, the key is location, location, location. I think in any kind of project, and especially with this technology, because you have technology assessment, because you have so many people involved from the organization, really, it's like you mentioned, communication, communication, communication. Tell people what you're doing, tell them what you did, and tell them, what you're going to do, tell them what you're doing, tell them what you did. Communicate, communicate, communicate. So again, just try to talk that provider off the ledge to scale it back a little bit, and then it'll be better in the long run if you get that little victory and move forward.
If others have thoughts, please do unmute yourself or feel free to type in the chat. Thanks for that guidance, Tim. The other one that ran through my mind is I think we lean into patient safety sometimes, just saying, hey, we just really want to make sure it's living up to the safety part. That just came to mind as you were talking.
Absolutely. That's always, of course, the bottom line, right? That's where it all ends right there. So, I'm probably like that provider. I get excited about some of the projects we talk about around here, and I'm like all in. I'm like, hey, let's put it all in there. But again, really, you kind of have to step back and say, does this make sense? What are the downsides if we scale huge? and it doesn't work versus a small. So just kind of look at it in the big picture, and you'll get there. You can get there quicker, actually, and more successfully if you start small and then grow. The last step of step 7, and really the whole process really is training. And this is, again, you want to ensure the equipment is used correctly. We want to clarify who is taking the training, as well as who will be giving the training, when will it be offered, how will it be offered. Is it something that training needs to be ongoing, so that if you have turnover in a remote location and you have a new telepresenter, you need to have someone come in and train those on the equipment each and every time. Do you have a set of documents, training documents that are fairly self-explanatory, so that can be sent out to the new employees or new responsibilities of someone, and then you can maybe do a quick training session on that. So that's always very important. And everything we do here, we train, we go through simulations before we send anything out or have someone out there with the patient for the first time. You don't want the patient to think you're having trouble working the technology. That doesn't necessarily instill a lot of confidence in that patient or the provider. So you want both sides to be able to step in and just work the equipment as it should. So, and that really comes from training. I think that is it on the 7 steps. So again, it looks like it's a lot, but really it does flow. A lot of this is just kind of covering your tracks, making sure you've gone through, making sure the technology, the devices, the equipment, really the system as a whole is working as everyone wants. The clinician is getting everything they need. IT has had their say so that it completely flows with the system and the technology they have. Administration's okay with the budget and how much things cost and replacement, and that we have things documented of why we did and purchased what we did, and that it works as it should, and that everyone is completely have the equipment they need and they're trained on that equipment. So kind of with that, and with my weird sense of humor, I do have a little cartoon. Huge Dilbert fan. I mean, probably showing my age. I'm not sure Dilbert's really around anymore, but and I'm also kind of started off as an IT guy. So, but just Dilbert's saying your user requirements include 400 features. The end users they're just kind of staring blankly. You realize that no human would be able to use a product with that level of complexity. So the end user saying, good point, better make it easy to use to the list. Well, but technology is not always that easy just to say it's easy to use. So again, something to keep in mind when you're choosing technology. And then we do have a couple of resources here. Again, the National Telehealth Technology Assessment Resource Center, where I got this toolkit, National Consortium of Telehealth Resource Centers, HTRC, and even a CCHPCA, Center for Connected Health Policy in California. Great in policy, but they also have a lot of up-to-date technology section as well. So please feel free to check any of those out, and always give me a call or an email if you have any questions. Now that I've stopped sharing my screen, I can see some things on the side. Any questions, comments? I see one from Alex Lee says, going back to requirements and scoping. Oh, okay, I think that's one we've been on. Gotcha.
I just want to say thanks, Tim. That was a great presentation and overview and reminder of resources available and kind of some guidance. So I do apologize. I had to take a call, so I missed the last few minutes, but I agree with Alex's questions. You said during your presentation, I'll say as a clinician, I feel like I can say this. It's okay to pick on clinicians because sometimes we're not the most reasonable and rational when it comes to this telemedicine or any other thing. So, and I think Alex is right. There tends to be, I'm generalizing, but there's two extremes, is that, we really don't want to do this, and the heels drag in. dig in, or it's let's do this full scale. So I think that was a good conversation. And I guess the question, if there is one, is, and this is really an outlier, I know. Many of the people on this know kind of my situation, but I do a lot of telemedicine, and it's kind of the flip side of that. I'm working with two different organizations, fairly disparate profiles. So one's in the college health field, and another one is, more traditional healthcare system. So I think I'm answering my own question, but as a clinician, I just kind of give my feedback because they're going to have disparate systems. Or have you encountered anything like that? And are there ways that, as Evelyn said, communication is key? How do I effectively give feedback to those organizations without seeming like I'm wanting to completely capsize the boat, so to speak? Does that make any sense?
Yeah, I think it does. I think feedback's good, and as long as you provide positives besides just negatives, I think that's something can happen is maybe technology is not that user friendly, or maybe someone who's using it thinks it could be easier, or I really would prefer the other device, or hey, I work with this device at another organization. It's fantastic. The one you're using, it's much better than the one you're using. Just providing positive feedback as well, as well as maybe something that doesn't work for you or you like better at another place. Just making sure it's not a complaint only, bringing that information there with maybe even a suggestion as well. If you have something that's, hey, I don't know if you're using product A, I'm using product B at another location. If you guys ever come up for want to replace these or need to replace these, you might look at this. I have a good success here. Bring it to the attention that, again, that you're not happy with it, but again, you have a solution or suggestion as well. I think is really kind of like through life. Don't just come to as a complaint, come back with an answer as well.
And you guys, this may be so obvious, but I've seen this happen many times. Don't go around your providers, right? So we're not scary, involve them early. Like I've seen, wow, people on the administrative side get way out in front, and then, oh, we haven't talked to the doctors. Oh, what do they think? So don't do that, right? That's a recipe for disaster. So involve people early, listen to them. I remember it wasn't you, Rachel, but back in the day when I was doing telederm and the whole high definition revolution came out and everybody came rushing to us. You guys need HD, and I'm like, no, we really don't. We can see just fine and have been able to for over a decade, So, it just involve your healthcare providers early and get their input and listen to them and make them part of the team. That would be my suggestion.
Yeah, and I like what you said, Karen. And I think a lot of people, I'm a technology guy, but yet I'm kind of, I won't say anti-technology, but like with new phones these days, right? a new phone comes out and there's kind of two groups of people. There's those that, hey, this new phone and it has a new camera, a new feature, and they go and buy this new phone, which is fantastic. But I'm more like you mentioned, the HD comes out. Do I need it though? Do I need a new phone? Are my pictures not crystal clear as they are? Do I want to spend my time and resources on that versus using that somewhere else? So I'm certainly one of those that, I don't just try to jump on things. Someone comes to me and says, hey, HD's out, you need that. Okay, how will that improve what I'm doing and at what cost will it be? So yeah, that's great. I think Heidi had a comment. Does anyone have experience in telehealth in nursing homes and skilled nursing facilities? And would any of these devices be useful there? I'm not a clinician, so I know there's several on here. Please feel free to speak up. From my experience, I would say maybe a telehealth cart would be fantastic. The patient is maybe not necessarily mobile. I don't mean to stereotype or generalize, but so a cart could be taken to each of the rooms. A horoscope is a great camera, and you can have multiple lenses. You can have the Odo the derm, all the general scope cams. Stethoscopes that we use are stethoscope as well as an ECG. So really have quite a bit of technology just right there that you could need for, I would say, a majority of what a patient might need.
And I would just say a cart would be great and ideal, but it's not absolutely necessary. I did a lot of telehealth in nursing homes back in the day, a lot of telederm, and most of them, the few that I serviced a lot would just have a room and they would bring the patient to the room. So, I mean, there are different models, but sure.
I agree with Karen. Basically, I currently work a lot in nursing homes, and yeah, telehealth, the card is great if you've got it, but I agree with Karen again. That's not an absolute necessity by any means.
This is Rachel. I would just add to that. It kind of depends on the model that you would be using for the nursing homes. So often in a nursing home, you're going to have a very highly skilled nurse that's going to be with the patient, and they could easily be the eyes and the ears for the physician on the other end of the camera.
Absolutely. And, again, I mentioned a cart, and carts are great because they are mobile. Downside to a cart, they can be very expensive. I mean, very expensive. Like you could easily spend $25,000 on a cart. I'm also, I guess, a little old school. I try to certainly keep things very simple. I know here, so you can buy a complete system or a cart, and it's configured into, Amwell and Epic, and it's just a complete 100% system. Very expensive. I try to keep things when you deploy carts. We use something very simple of Zoom, and we use Epic at OSU, but yet we don't have that connected into the cart. The provider has two monitors, so they're able to see the Zoom here, and they have their own Epic up here, so they can make notes, and the nurse that's there on site, they have two monitors, they can do that as well. So there's ways around keeping technology I won't say cheap, but less expensive than what it can be. So
I'll throw out too, as a psychologist and mental health person, just lots of opportunities for telebehavioral health in nursing homes and skilled nursing. I know early on in telehealth, there was some worry about, acceptability with elders. There's a lot of good research that you have to cross your T's and use our same good relationship skills, but that telebehavioral health can be effective in meeting needs of both the patient in the facility and also for caregivers.
Anything else? I think kind of a takeaway again is just, technology is there to help, to assist, right? So don't try to make it more complex than it is. If a product meets your needs, in my opinion, is don't necessarily go looking for something, a more expensive, more complex, device that will still do the same thing as maybe a cheaper version, something easier to use. So it's there to be to supplement and to help clinicians. And we have some great technology. A lot of technology is still coming out. It's really just kind of certainly changed the way, we communicate, even like what we're doing right now. So yes, sure.
So you mentioned OSU and Epic and Zoom. So I'll just poll you and the whole group, I guess. What is the state of the industry, if you will, right now? Are most healthcare organizations, is the telemedicine integrated into the EMR? Are they kind of using both, or is there a current trend on where that's at?
I think they want to get there, would like to. I don't necessarily think they are at this point. Karen, you were kind of shaking your head. You have more feedback on that?
Well, there's a lot of effort. There's a lot of energy behind the legacy electronic health record companies partnering with the direct-to-consumer companies and trying to integrate those technologies. But in my experience, it's always harder than it seems on the first blush. And prices can vary very widely. You can spend a ton of money on telehealth or virtually nothing. And so, if you're I wouldn't weight your program on promises of technology integrating. Somebody can sue me for that, but that's just the incentives are sort of misaligned on that. You can see a patient over video conferencing over Zoom with a $50 Zoom license and then turn around and type your note into your electronic health record. Boom. You can do that today, right? So you just have to kind of get your head around that. How much money more money is not necessarily better.
Thank you. That's very reaffirming what I believe, and many of the rest of us may have. Well, we have to get it integrated into EMR. It's kind of like the telehealth cart, right? There, like you said, there's a full spectrum of ways you can effectively get into telehealth. Thank you.
Yeah, again, I think I said earlier that just be careful with any kind of a vendor or salesman, nothing against vendors or salespeople, but they want to sell your product. They want to sell you a fully integrated package, but just again, keep in mind, those are fantastic, but there are other options out there as well. So really depends on your organization and your budget. It's like a car. I can buy a used car that gets me to work at 30 miles an hour top speed, or I can go out and spend however much and buy a high-end car. So it just depends on what your budget is. By the way, I do not have a high-end car. No.
It looks like we may have one final question about Azalea integrated telehealth. That's not one I'm familiar with.
Yeah, I'm not sure I've heard of that integrated into their EHR. Does anyone have any experience with Azalea? Heidi, is that something you're using now or potentially looking at? Sorry, we can't quite hear you.
Rachel, is that the company that American Law bought?
No, that was Avizia.
Okay, Avizia. Okay.
It might be an electronic health record that is geared towards nursing homes. No, she's shaking her head.
We'll circle back. I'm sorry we weren't able to hear you, but it's a great question, Heidi.